just listening to, you know, or seeing all of you on the screen, I'm really just grateful for this opportunity to be able to share a part of our journey. And so many of you on the screen have contributed to the Aspires project. So I actually represent and present this on behalf of many of us. As Mark says, I have a background in clinical nursing and then spent some time in practice development and research. And I'm certainly a visual thinker, and in all that time in doing clinical work, as well as the early years of research, I've always had a real interest in trying to find ways to make complex clinical practices visible. And so in our time together, I'm going to introduce how we use visual maps to investigate team communication on infection management. But I'd just like to warn you that this is more of a right brain presentation, and hope to stimulate your thinking a little bit more around that. But I do see this as an opportunity to really to learn from you as you listen to the talk. I really want to encourage you to engage from your own, or think about your own experiences. And there will be a time for questioning and answers later on, where I would really appreciate your input. So this is the map of where we're going to be going. I'm going to be starting off with communication and why it's important. And then we're going to go on to look at the Aspire study, followed by key learnings, and especially around the development of a visual mapping tool. And then I'm going to end with introducing you to my PhD study proposal and how we are now able to take this work forward. So really the question around why communication is important, and we know that interdisciplinary communication in healthcare teams has been studied extensively, and there are strong links between communication and poor patient outcomes. From America, we see that communication failures are responsible for 30% of malpractice claims. I can't find similar data from our context. I think it's also important to note the influence that aviation has had on healthcare, and it was especially around the 1970s where aviation found a strong causal link between non-technical skills and errors. And these non-technical skills relates to communication and leadership, teamwork, decision-making, and situational awareness, where up until that point were kind of considered as soft skills, and not and there weren't really connections between the impact of that on outcomes. And since that time, the non-technical skills have been studied quite extensively, and the impact on patient safety, especially in anesthetics and critical care. So communication, broadly described, are the skills that are needed to work in a group, where a shared picture of the situation is understood by all, and where there are clear, timeless information exchanges to complete the task effectively. I want to show you something which I'm sure you probably had exposure to, and this is the communication process. And it's really to, I suppose, emphasize that communication is really not that simple. So this indicates communication between two people, between the sender and the recipient. And the channel is really the medium, or how we submit the message. So whether it's face-to-face communication, whether it's written, whether it's telephonic or over a device. When the sender sends the message, there's a process of encoding, and that's really where the way that you've prepared the message, or the way that you're sharing the message, is appropriate to the channel. So I've had to prepare a message in a certain way to be able to communicate it via a Zoom platform. I much would have preferred for us to be in person, where I could kind of see your responses. And at the moment, I'm kind of looking at a blank screen, and I would love to just see your faces so that I can engage with you. But obviously, that's not possible. So the encoding is really making sure that the message is appropriate to the channel. And then how the recipient decodes the message really depends on a number of factors are determined by the recipient's frame of reference. So in effective communication, that whole process needs to be repeated once the recipient receives the message, and which then follows an encoding and a decoding. And there's some acknowledgement that the message has been received, which you would have heard of referred to as closed loop communication. So just before I go on, I really would just like you to think about a recent personal interaction where your message delivery may have been affected. So what happened to either make that the process of communication effective, or what was a barrier that you experienced? And then I'd also like you to think of a recent interactive space with your teams. So what helped or hindered the communication in that process? And I can think of an example of attending a ward round yesterday, where I was standing on the outskirts of the round, sort of on the outer limits. And the person who was presenting was speaking very softly, and they were wearing a mask. And so it was very difficult to encode the message because I wasn't able to actually hear what was being said. So it's interesting that there are many things that will influence or impact on the flow of interdisciplinary communication in hospital. And as you're sitting there, I'm sure you can think of a number of factors that might not necessarily even be mentioned on the screen or in this presentation. But the author Lou and colleagues suggest that there are two main categories of factors that either hinder or help the flow of communication. And maybe just think of whether you can recognize these. The first are physical factors, which enables or hinders physical accessibility, and they relate to the physical space. They also relate to, interestingly enough, rounding schedules or the times or periods when people plan to meet, and whether everybody who's supposed to be there knows about that. So that's are they able to physically access? Then also, do we have the access to the right person? So for example, if you've got to hand a message over to another person, are you able to contact them? Do they answer their phone? You know, I'm sure you can think of a number of things there that can either help or hinder. Then we look at psychological accessibility, and I'm sure you can recognize many of these. This relates to hierarchy and leadership. Then there's something that I'm quite interested in, and it's referred to as cognitive bias, and that's our inherent bias that we have towards either another profession or another kind of person that either enables you to hear the message clearly or hinders. So maybe you've had a negative experience with a person, and the next time they speak, you immediately feel like there is something in you that's not able to completely encode the message that they're sending you. I mean, that's a negative example. There are many positives in those as well. Then there's the interesting point around gender, around professional barriers, which we certainly do recognize within our context. Relationships, whether there is relationship or not, how does that kind of interrupt or facilitate the flow of communication? And then definitely the role of personalities and behaviors. The ward rounds are obviously the place where a lot of these interactions occur in the healthcare settings, and you know that many of you are a part of those. And the quality of interactions there impacts on patient outcomes. There are some challenges, and some of them on ward rounds are related to the inconsistency of attendance, unstructured handover formats, and high patient loads. And these are not common in to many of the settings that we work in. So over the past couple of years, there's been a massive effort to improve rounds, which is specifically focused on standardization, improving structure, as well as wider engagement, which I'm going to talk about a little bit later. So these ward rounds and communication within these spaces, they happen every single day. They're normative, they're routine, and often the complexities of the interactions are invisible to the role players. And that is what our work is about. Our work is about observing how teams work together in the activities of everyday doing. So now to carry on and to just tell you a little bit more about the ASPIRE study, who many of you are well aware of. Many of you have been participants in the ASPIRE study. But this study aimed to look at optimizing antibiotic use along the surgical pathway. Ismita Charani was the project lead, and Mark was the South African PI for the study. And this study was conducted across 3 countries. It started in the UK, and then was also carried out in South Africa and in India. It was really motivated by the fact that up until that time, there was a lot of work across the globe that gave us insights into the size and the extent of antimicrobial resistance. And the ESRC, which is the Economic and Social Research Council, really wanted to use social science research methods to better understand the contextual and cultural factors in order to then tailor interventions to optimize antibiotic use and infection prevention and control. And so this study was, as I said, it was started in the UK and then branched out to South Africa and India. And we've got some of our Indian colleagues here today. So what we did in South Africa was really just one of a small part of the puzzle. And the study sites were specifically selected because they had already existing well-functioning stewardship programs. Oopsie, wrong way. There we go. What you will remember about the study is that it aimed to look at an in-depth study of how surgical teams make decisions around antibiotic prescribing and infection prevention and control. And this was really one of the first studies, and this was why I was so intrigued when I had the interview, was because it was really aimed at understanding the effects of human behavior on clinical practice. And before the study, I hadn't really been exposed to anything like that before. I think it's important to mention all the work that went into kind of building up towards the ASPIRE study that we did. And this was led predominantly by Ismita, who has been a role model to myself and Uluchi, and she's been instrumental in the ASPIRE project. But she did an extensive amount of work applying social science research methods to understanding prescribing practices amongst healthcare professionals. So if we look at the first study on the right-hand side, there was a gap in the literature that led to a systematic review that highlighted that there were some social determinants motivating antimicrobial prescribing. This was then followed by interviewing health professionals who had a role in antibiotic prescribing in hospitals. And an interesting finding there, and this is something that we've continued to be aware of, was that in prescribing behaviors are not linear or a one-to-one interaction, but they are complex processes that are influenced by many determinants. This then led on to an ethnographic study, which formed the foundations of our work now, where Ismita looked at the differences in decision-making across medical and surgical paths. And what they found was there were differences in how teams made decisions on antibiotics. There were differences in who carried the responsibility of making those decisions. And the important thing was that, that for interventions, obviously one size does not fit all, but that you needed a bespoke sort of plan for each team. So there was a growing body of literature really that pointed towards the fact that that the surgical pathway also had a high risk of infection and AMR, and that led to us looking at surgical pathways in the spines. So this is a very oversimplified picture of a patient's journey in hospital, and here we can see various specialties, different teams that work together along this pathway. And our assumption is that when there is the policies and guidelines, that healthcare workers will comply to these, but we know that decisions, any decision and decisions around antibiotic prescribing really happen in complex environments where many people have different priorities and targets that they're working towards. So in order to improve something, you really need to understand the context in which people are working. So the Uluchi and I were employed to work on the ASPIRE study at the Cape Town study site. In parallel, this was also happening at Amrita Hospital. And we were focused on understanding antibiotic prescribing practices in the cardiothoracic surgical teams, as well as gastrointestinal surgical teams. We used a methodology, which I'm not sure you are familiar with, but it's called ethnography. And what ethnography really does is to observe behaviors and interactions in a group for an extended period of time to get a deep understanding into shared cultures and social dynamics. So for 4 months, I think it was 4 months, Uluchi and I literally followed the cardiothoracic and GI surgical ward rounds for 3 mornings a week. And we observed team interactions, and we observed how decisions were made. And these were captured in field notes, which give you a very rich description of what is happening. Together with the ethnographic observations, we also did interviews, and that was to find people's, to try and elicit experiences around antibiotic prescribing, and just how different healthcare workers were experiencing prescribing practices and IPC. But in addition to this, and especially because we were observing a lot of ward rounds, we had an opportunity to observe how teams were interacting at the bed space. And previous work that I'd done, we'd used something called sociograms, which are visual maps. And visual maps really help, or actually are graphic representations of social links. That is, that a person has in a group or situation. We had an opportunity to apply sociograms to enable the visual representation of position and verbal contributions of ward round participants. This was work that we had done at Red Cross a couple of years back, where the ICU consultant was really interested in understanding or seeing whether parents were engaged during ward rounds, and he engaged me, and he said, is there a way that we can map this out so that we have a visual output? And that was the early work, and just so grateful now that in the Aspires we have been able to develop this further. So really what the visual maps are is that it's a basic representation of, sorry, I just want to get let me just start that again. So the way that we're able to capture interactions between people is using a directed graph, and a line represents communication. The direction of the line will show you who's talking to who. And then the little symbols represent people. And obviously we looked at which categories of healthcare workers there were. And then after spending a lot of time collecting ethnographic field notes, we were able to come up with various themes that related to infection prevention and control and antibiotic prescribing. So this is these are the keys, the communication themes that we came up with, and there you can see below that are the people who were mainly involved with communication on the ward rounds. So I just want you to take a second to kind of have a look at what's happening here at the image on the left-hand side. Here we can see how various attendants to the ward round position themselves around the bed space. Then we can see lines of interaction, so you can see who's talking to who, and eventually we started to understand that you can add colors to the content of communication, so that you've got a really good idea about what is being spoken about. I think some amazing progress that we made with this is that we were then able to actually count communication. So we ended up with a product which helps to measure communication quantitatively, I'm sorry. And so at the end of the Aspires project, we had over 70 hours of observations, which included 1,024 bedside consult, which Ulichi and I observed. We did 61 interviews with various healthcare workers from the surgical specialties, and then 20 sociograms that we were able to measure from each of the surgical teams. So just to speak into the results and implications, here we have an example of ward-round interaction once again. This is a visual map of communication around a patient in ICU. And you can, well, I don't know, it's probably a little bit difficult to see, but there's a broad band of many arrows in the middle of the bed, and that's the registrar doing the initial update. And then from there are many there's lots of communication happening, especially between the consultants and the registrar. So if we look at the symbols, the consultants are triangles and all the registrars are circles. So what we found with most of our observations and with the sociograms is that the flow of communication about AMS and infection management is primarily between consultants and registrars. This might not be surprising because it may be the purpose of the round is to discuss certain aspects of the patient, but it was an interesting observation. We also noticed that where people stood around the ward round actually determined their level of engagement. So there was a link for us between positionality and engagement. People who stood within the inner circles tended to be more engaging, while those who stood on the outside were not often engaged or didn't often make a contribution. I think what's important to just emphasize here is that we started to notice, especially around infection management, that a lot of members from the surgical teams had roles and responsibilities in infection care. And so when we looked at this, it was then interesting to see whether that contribution or offering was translated to the ward round space. And this particularly with nurses who have active roles in infection management. We didn't often see them either being engaged or offering information around details, patient details, or anything that they'd noticed. Now, somebody said yes, but those conversations may have happened outside of that ward round space, which is definitely important to note. But I think the important thing is that we found ways of observing, and so when we make these observations, it's something that we can then take back to the teams and say, what do you kind of make of this? The next result relates to the consistency of focus on AMS and infection management really vary across the specialties. So on the left-hand side, we have a structured update, which routinely provides information on infection management. So the lines are mentioned routinely as well as the antibiotics. And those would be mentioned even if the patient didn't have an active infection. And on the right-hand side, is an example of team interactions where the information around infection isn't necessarily mentioned in the update, but through a lot of process of eliciting lots of questions, the consultant, who is the triangle, needs to find out about the patient's infection. So it's really just was interesting to note the difference between these two. Just on that matter, we had another way of depicting this information relating to the consistency of focus on AMS and IPC. This is an example of a sunburst chart, which is from sociograms that were taken from the ICU. And it helps to see who was talking to who and about what. So the first ring is the initiators of communication. So there we have the registrars, and you can see, so that's the lighter blue and on the right-hand side. And they mainly talk in their ward rounds to the group. The ICU ward rounds, they give quite a long update. But what I'd like you to notice is the fans of orange, of yellow, green, pink, and red. And those are, and you can notice that they're similar in width. And that was because for each patient, infection management and antibiotics were consistently measured across mentioned to the group for 20 patients. So that would obviously look different for different rounds. And then interestingly enough was that the consultant leadership styles really influenced ward round dynamics. We found that as a norm, some consultants included members, non-medical members, by asking questions, by engaging them, asking for contribution. And it was interesting to see some consultants the people from the non-medical staff would naturally move towards the center, so they wouldn't stand so far on the outside. And also we noticed a lot of direct communication, so specifically related to the starting of antibiotics or stopping lines. It was a direct order that was given to a nurse or somebody else who had to carry out the action. So visual mapping has really highlighted interesting team dynamics, including varied leadership styles, unequal contributions by team participants who have critical and different roles in AMS and infection prevention and management. And yeah, overall, we did find that there was a limited interaction with patients on the ward round. We had some limitations to the study in that they were limited to consultant-led rounds, and that the morning rounds are not a complete reflection of all communication, but we know that. And so we've always got to be watching in the context of what else is happening. A key recommendation really for this, and one that I'd really like to mention, is applying sociograms as a tool to prompt team reflexivity, which is something I'm going to be speaking into, which I've picked up for my PhD. So we had an article published, which was fantastic for us. We're very, very proud of this. And then we also had an animation, which I'm actually not going to play now because I'm concerned about time. But I will send out a link if you'd be interested to watch that. Okay, so now going on to key learnings and really the key things that we've taken forward in developing the visual mapping tool. I think the first one is the importance of ethnographic observations. The key thing is we learned is that visual maps cannot be captured in isolation of understanding the context and the essence of how the team works, specifically looking at how teams make decisions, who's involved. Every ward round has got a different emphasis, it's got a different focus, and so those are really, really key to kind of keep in consideration. The next thing we learned was the importance of feeding back the research to participants. This is something we did because we wanted to engage them in the findings. But we were really surprised at what they experienced from seeing their own practices reflected to them. So we presented sociograms to them and helped them to see sort of patterns of communication. And this led us to see the importance of reflexive teamwork, which enables teams to analyze their own practices so that they can decide on potential interventions. So we developed the visual mapping tool, and it was practical and adjusted to suit the inquiry. We could do that, but we also noticed that it needed some improvements. The one improvement was that sociograms that are hand-drawn are individual depictions of an incident around or an instance of communication around a bed space. But sometimes these were quite hard to analyze just from Sorry, I just want to just go back to talking about the visual mapping tools and improving them. Other than how we improved them, I just wanted to add here that there were different ways in which we could depict them or illustrate them to the participants to aid reflexivity. So that was the one way, is the actual hand-drawn sociogram. And then we also looked at the sunburst chart, and what's really nice about this is that it can highlight patterns of communication. There's another one called the Sankey chart, and in this one, there's a comparison between two specialties, which is looking at initiators and recipients of plans and instructions on ward rounds by specialty. And here we can just see on the left-hand side who is talking to who around specific plans and instructions. So in specialty C, the plans are mostly given to the registrar by the consultant. And then, yeah, we can see there's very little of that from specialty A. The next thing that I'd just like to touch on is the visual mapping tools and how we improved them. So sometimes sociograms are very complex, especially in long ward rounds around a specific patient. And so what we found was difficult. It was difficult to take out counts of communication for us to analyze this. And so we've redesigned the capturing counts of communication to now sequence the counts along a timeline. And this was always, Uluchi always inputted on this, and she said, you know, the directed hand-drawn sociograms are great, but you actually can't see when communication is happening about what. And of course, like the sequence of communication is really important. On the right-hand side here, we can see the registrar gives a sort of a standardized update, and then this is followed by engagement from various ward round participants. We were also really pleased to get engaged buy-in from our lead consultants. And I just asked them to write something about what they experienced around sociograms and just having their own practices reflected to them. And this was from Dr. Pennell. And he just said that sociograms are a reflection on the power dynamics that happen on ward rounds independent on decision making. And he certainly could identify with the decision making that was altered by hierarchical attendance, and it really helped to change the way we practice. And then Professor Hubert said that it gave him a bird's eye perspective on the interactions that were happening. And he said that you could see the whole game as it played out, and certainly helped to improve interactions with the team and to deliver healthcare with heightened levels of team inclusivity. And Prof. Hubert came to us at the end, and he at the end of the Aspire study, and was really interested to take this forward. Now to take this forward into a PhD, we've got so much to work from and to work with. And the aim is to see whether we can use visual mapping approaches and team reflexivity to lead to better understandings on team dynamics. So for the PhD, we've included medical and ICU teams. Medical teams really like to look a little bit more around communication on infection management, whereas ICU have asked us to look at how they could optimize outcomes of ward rounds. And so the overarching goal is to explore current communication practices and implement contextually fit solutions. And importantly, we want to develop an adjustable and flexible visual tool to capture and analyze real-time communication, which we'd love to then develop into a framework to evaluate team communication. So the PhD will be delivered through the following objectives. And the first objective really is to try and understand what is currently happening around practices, around team dynamics, around mechanisms of communication. And then what we'd like to do is to use a process of team reflexivity to then feed the data back to the various teams, and for them to, in the third phase, look at a process of implementation, which is a quality improvement process. So for the research, we will be using the same methods. We've tried and tested them. They work. They are reliable. And I'll start off with piloting the data, and then doing ethnographic observations as well as sociograms. To this, I will also add focused bed space observations, which help to kind of investigate formal and informal communication at the bedside. And this is often interesting to see after you've observed a ward round and the decisions that were made on the ward round, then to carry that through to a bed space observations to see how some of those decisions that were made are actioned. And then we'll also be interviewing healthcare workers really on their perceptions and experiences into the overarching research question. This will then be followed by a team reflexive workshop and a quality improvement process. I have started a scoping review because I feel that it's important as a baseline to this work to understand the existing mechanisms of communication and team dynamics, which are currently have been tested in hospitals. I'm not going to go into a lot of detail around this. I just wanted to talk you through this, but I think just for a matter of time, I'm just going to scan through this. I've identified 537 articles, and we were able to include 53 into the final review process. Just some interesting findings, very, very early findings, and we haven't even really done a proper process of analysis, is of the 53 studies, 100%, 53 out of 53 are from high income countries. So that really highlights the gap into our context and into future work around what is happening around communication and teamwork from countries such as ours. I think it's important or interesting to note that most of the studies were conducted in adult settings or with adult patients. And then 34 out of 53 were intervention studies. And out of those, only 8 demonstrated direct links to patient outcomes. But most of the studies did investigate and improve some aspects of team communication. So really just as a very early kind of outcome from the study, we have found that if effective mechanisms of communication are about how we structure and standardize communication to ensure that that no information is left out. Secondly, the literature indicates that there have been mechanisms to enhance and widen collaboration and input into patient care. But the analysis shows that there's only a small direct effect on patient outcomes measurable. I mean, we know that there's so many other confounding factors to that, but that it does impact on patient care, looking specifically into those themes. And lastly, it affects team dynamics. But to understand all of this, we really do need to consider what affects the flow of communication. So things like that we discussed earlier on, like cognitive bias, leadership, professional barriers, and especially the system-wide factors and the environment in which teams practice. So where are we now? So I've started a data collection with ICU teams and with medical teams. I've done 4 weeks of pilot data collection, and I'm currently in this space to collect ethnographic observations. I attend ward rounds, so that's where we're getting most of our information from. Sure, I feel like I've really rushed that in part, and I'm very, very sorry about that. But I just want to thank especially my supervisors, Mark and Esmita, just for your massive contribution and enabling of this work. Lucia and I have been supported since the inception of the Aspires project, and my growth has been phenomenal. So I just want to thank you for that. And then also colleagues from University of Cape Town and Rita. Thank you very much. Thank you.
Candice, thanks very much indeed for a wonderful talk and for all the work that's gone into it. For colleagues outside of the Western Cape, you'll have heard a bit of whistling in the background. Candice, if you can just stop sharing your screen for a sec. Unfortunately, the southeaster wind is whistling through Huddersfield at the moment, so that's what you've been hearing. I think we are joined by Esmita from Lisbon, and I think in all honesty, really, supervision, Candice's supervision, and a lot of the inspiration for this work, it comes from Esmita, and I really want to acknowledge that. And I don't know, Esmita, if you'd like to kick the ball off, the discussion off in terms of some comments around this, while people are. If you would like to make a comment or ask a question, if you could raise your hand, that would be great.
Thank you so much. Well done, Candice. And I think Mark's being very modest. Really, we couldn't have done any of this without the leadership we have from Mark and the collaboration of our surgical colleagues and ID colleagues, all of you. So it's been wonderful, but it's nice. It's so wonderful that we can carry on the work even after Aspires has kind of folded. I think it's really nice to hear from everyone about how we can support Candice's PhD going forward, because it's at a point now where we can still make changes and make it as of use to the teams on the ground there as possible, which I think is, this project has potential to do that. So I think it's just over to everyone about what you think of the work so far. Are there areas we've missed, things we've looked out, we haven't looked into, and we'd be delighted to hear from everyone.
Thanks very much. One of the things listening to your talk, Candice, is how important this sort of work should be in even introducing it to the healthcare student setting. So obviously medical students, but nursing and pharmacy and everything. One of the things that strikes so often on looking at your work is the positioning and the interaction of nurses and pharmacists, particularly on ward rounds, particularly on stewardship rounds. In the experience in Aspires and in your experience so far, has what happened in Aspires changed how those people are being interacted with within rounds in your experience now in the ICUs? So has just doing this work changed that aspect of things?
Thank you, Mark. I think from what I've observed that it has quite a lot to do with ownership and awareness of their own interactions. So I think that, so for example, Professor Hubert has, he's owned this, and he's made an intentional, he's made it his intention to include nurses and pharmacists on the round. So when I watch his interactions on the round, there is an intentional inclusion of both of those. So I can't say that's necessarily the norm. And because it's not happening, it doesn't necessarily mean that it's wrong. So I'm always so nervous of kind of stepping on toes and saying, like, this is what we're seeing. And, it's not a norm at the moment, but it is becoming the norm for some practitioners. And I think that's what we'd like to aim towards, is that kind of, I think it's about like a heart buy-in as to why it's important, so that it can be kind of be accepted as a way of practicing. Does that make sense?
Yeah, no, it does. And the other thing that sort of alluded to, but maybe you want to just say a bit more about, and I wonder actually if Verinda also would just comment, because the communication with the patient varies greatly in different teams and different ward rounds. And I was just, so I'd be interested in your thoughts, but also Verinda, in a setting like in India where patient carers, and I know this is something Anucci obviously is very interested in and looking at, and so she may like to comment as well. But how much do carers benefit the patients in being able to also be almost a translator or conduit of information? So Candice, maybe first to you and then to Verinda, and I'm sure colleagues will have other questions.
So I think my first thoughts around that is that it's related to the individual rather than a norm of practice. And so we did see certain consultants repeatedly engaging the patients, and I continue to see that on the ward rounds that I'm attending in the medical specialty, where there is such a clear intention to speak to the patient, to explain procedures to them, and that's given the number of patients that need to be seen and I guess the limited time they have, but I see the intention, and it's a real leaning into to enable the patient to understand what has been discussed, and that happens with every patient on some of the ward rounds that I'm seeing now, but I'm connecting it to individuals rather than norms of practice.
Yeah, so it's so easy to forget there is actually a central focus in the bed next to you when you're having these discussions. I'm very cognizant of it. Vrinda, what are your thoughts?
I think in our setting, the role played by patient carers, who are generally family members of the patient, is quite critical. And the hospital also expects the patient carers to be with the patient when he or she is in the wards, especially. But what we find is that even though they are expected to be with the patient to run errands for the patient and things like that, their role in IPC or antibiotic decision making is not well recognized among the surgical teams. So there is a subtle role that's being played by them. And even during our observations and interviews, we were able to find that, but it was not well recognized among the surgical colleagues.
Thanks very much indeed. So Sean, your thoughts?
Hi, Candice, thank you so much for a wonderful presentation. As always, it's really great to keep on hearing your work. I have a question about translation. So I mean, you're collecting all this information, you're gaining these insights. How do you think this can translate into better antibiotic stewardship, better clinical care? So let's say your project is successful, you achieve the hypothesis that you have. I mean, what the next steps be to kind of take this even further?
So Sean, that's why the phase 2 and 3 of the PhD process are essential to our outcomes. We don't want to do research for research outputs. We want to do research that changes clinical practice. And so I might have rushed through it a little bit quickly, but in phase 2, it's about engaging teams in what we find. So they get to reflect on their own practices, and then they get to decide if there are aspects of team communication that they want to address. And then we go on a quality improvement process, a thorough quality improvement process to bring about change. The overriding, objective then is to develop a framework that can then be adjusted to any context. So for example, another team, like in neurosurgery, can say, we want to analyze our team practices. Can you come in and can you, we do sociograms, we do ethnographic observations, and then go on the same process. So the idea of this really is to make sure that whichever teams we engage with, we change some aspect of clinical practice.